It's a real pleasure to be here to speak to you on this topic today of LHON diagnosis and treatment in the United States. I am working as an investigator on some ongoing trials with neuroth as described, and that's not really relevant to this topic that I will discuss today. So in some cases, the diagnosis of LHON is pretty straightforward for our patients here in the U.S. Typically, as is classically described in textbooks, a man in his early 20s might have experienced vision loss in one eye. In this case, 4 weeks ago, he presented to us with painless vision loss, no history of trauma, no recent illness. He now has vision loss in his left eye. His visual acuity was 2200 in both eyes. He had poor color vision. He had no RAPD, and his fundus exam shows that he has hyperemia of both optic discs. Some might even interpret this as being swollen. In this particular instance, this patient underwent a fluorescein angiogram that did not show any true disc leakage, just to rule out other potential causes such as optic neuritis. And he has a little bit of engorgement of the retinal venules, a very characteristic picture given his age, given his sex, given the sequential presentation that this has a high clinical suspicion for being LHON. But what about this 61-year-old man? He awoke with blurred vision in his left eye and a central scotoma in his right eye. He said these came on at the same time. He went to see an optometrist. The optometrist diagnosed him with an eye stroke and sent him to an emergency department. And in the emergency department, they did the things they usually do. They did a CT of his head. They did a CTA of his head and neck with this diagnosis of eye stroke. They did an MRI of his brain and orbits that was unrevealing normal. And 2 weeks later, he was seen by an ophthalmologist who found visual acuity of 20/80 in the right eye, counting fingers in the left eye, a possible RAPD in the left eye, although that ophthalmologist was not sure, and said the patient had swollen optic nerves and sent him for our evaluation in the neuro-ophthalmology clinic. When he came to see us, his visual acuity was similar to what was shown here. He did not have an RAPD, had briskly reactive pupils, which was one of the things that was against having had a so-called eye stroke or NAION. And importantly, visual field testing showed that he had a central scotoma in his right eye, a secocentral scotoma in his left eye. And this is a very important differentiator in diagnosing something like LHON, which affects the central vision and tends to preserve the peripheral vision, unlike this alternative diagnosis of NAION that he had been given. An OCT was done at that time, and it showed some early temporal thinning in the left eye more than the right. The left eye was more severely affected. And the macular ganglion cell complex, as shown on the right here, was thinned, again, more in the left eye than in the right eye. So after some further conversation with him, in which he revealed that he had been drinking alcohol heavily for the past 3 months because of a number of stressors that had arisen from a bad family situation, we were even more concerned that this could be LHON as opposed to some other type of toxic metabolic or nutritional optic neuropathy that could affect the central vision. So diagnostic testing is a key part of making that diagnosis, of course, in that 23-year-old man, especially prior to the widespread availability of all these genetic tests as shown on the right here in some screenshots I took from a number of companies' web pages that offer LHON testing. We might not have even tested that 23-year-old man. Now, neither of these patients had family histories, and so that may have pushed us toward doing it, but it used to take a long time, was very expensive. Now it's much more accessible, and we typically would start with the common mutation screening for the 3 most common mutations as shown here. Mitochondrial sequencing has been suggested. It's more time-consuming potentially because the mitochondrial DNA is highly polymorphic. It can result in the identification of abnormalities that may or may not be clinically relevant. And here in the US, we have to worry about insurance coverage for these patients for these expensive tests. And for LHON, whole exome sequencing typically is not done, although we have recently done that in a few patients with an LHON phenotype for whom mitochondrial sequencing was unrevealing. And in fact, in 2014, there was a consensus statement from the Mitochondrial Medicine Society on the diagnosis and management of mitochondrial disease that was published in Genetics in Medicine. And this paper suggested that point mutation screening, now this is again talking about all mitochondrial disease and not just LHON, that point mutation screening was insensitive enough that they recommended massively parallel sequencing, next-gen sequencing in the majority of patients presenting with a mitochondrial phenotype. And these tend to be more complex neurological presentations. Similarly, testing a tissue other than blood if suspicion is high because of the heterogeneity in the mitochondrial populations in different tissues. And then finally, as I mentioned before, next-gen or whole exome sequencing for nuclear mutations, again, more centered around other mitochondrial disease and not so much LHON. But getting back to LHON diagnosis and testing recommendations, we tend to follow, and I think most centers in the US would follow the recommendations that have been updated continuously since they were first published in 2016 and updated most recently about 2 years ago, in which targeted mutational analysis for those 3 common mutations is done first. This needs to be done at a reliable lab. I showed you a couple of slides ago that there are a number of laboratories out there that are providing this testing. And while I would assume that all of them are CLIA certified, it's not entirely clear that they all have the same sensitivity and specificity in terms of the test strategies that they are using. Second line, if the targeted mutational analysis is not revealing, would be to consider multi-gene panel testing, as shown here, NADH dehydrogenase, and then the numerous ND1 through ND6 genes. Finally, if that is unrevealing, and clinical suspicion is high and there's no evidence for paternal transmission, then there is the potential to go ahead and do complete mitochondrial DNA sequencing, keeping in mind that these variants of unclear significance may be found. Now, I have been doing this on a routine basis. I can tell you that I have had patients with a clear LHON phenotype who have had mitochondrial mutations found only on complete mitochondrial DNA sequencing, and that those point mutations were unique, potentially pathogenic, and it was important in following those patients who had come with alternative diagnoses like optic neuritis. So that brings us to the treatment side of things. So here we have a list of all of the approved therapies currently in existence in the United States. And this page was purposely left blank because, of course, we don't have any currently available FDA-approved therapies. Now, that doesn't mean we don't try things. And in particular, idebenone, supported by the ROTOS study and other studies over time, is often recommended to our patients when we see them. Now, it is available in the US as a nutritional supplement. Typically, we do recommend the 300 milligrams TID that was used in that ROTOS study, but this can be very costly. I don't think you can read the prices, again, on some of these screenshots that I took from websites that sell idebenone to US residents, because this is a nutraceutical in the United States, so that has 2 problems. One is that the pricing varies widely, and another is that the quality can vary widely. And in fact, one particular company that I know, a colleague of mine, had been recommending in terms of being a reliable source of idebenone, no longer seems to be selling it as of a few days ago when I checked their website. So there really is not a durable, quality-controlled, regulated supply of this drug. Other treatments we have, potentially low vision rehabilitation, nutritional and lifestyle advice, certain medications to avoid that increase the potential for oxidative stress, and then we direct them to local, state, and federal resources that help them to function in their low vision setup, in their low vision status. And so, of course, we are now directing them to clinical trials that may come into existence for which they could be eligible. So ultimately, when we see these patients, we have to think of the diagnosis. That first patient, everyone would have thought of the diagnosis. The second patient, maybe not. And it just takes some awareness to make sure we do it correctly. We have to order the appropriate testing. And here in the US, we tend to escalate the approach as needed, starting with common mutational testing. The costs vary widely. Our treatment is supportive and conservative, really, maybe idebenone on top of that. And then I didn't touch on genetic counseling, which has become more and more of a key part of the management of these patients, helping them to understand their potential for passing on or not passing on this disease to others. Thank you very much.